Our next lecture is going to be on the urine chemical properties. We're going to start the chemical properties. Remember I told you every pad on that strip we were going to start talking about? This is where we're starting. Actually, specific gravity, the last lecture was the first pad. This one we're going to talk about pH and the protein pad. So we're going to start talking about pH. So pH, what is it? It actually is the negative log of hydrogen ions, okay? Anybody that took chemistry, we had to learn all those silly calculations. I couldn't do them to save me now if I had to, but that's okay. Pretty much what we have to worry about in urinalysis is relating it to the acids and the bases. Are we dealing with an acidic urine? Are we dealing with a basic urine? What's happening? So the greater amount of hydrogen ions, the more acidic it is, the lower the pH. Right? The higher acidic, the lower the pH. That always throws me off. It seems like it should be backwards. The higher the acidity, the lower the pH. The lower the acidity, the higher the pH. So the greater of the hydroxide ions, the more basic, the higher the pH. We add them together, it's a neutral pH of 7. Deionized normal tap is 7.00 or 7.0. One note, your water in your faucet at home probably is not 7.0. Found that out the hard way. For a project I was doing for high school students, the tap water in this building is pretty acidic. And I did not know it. And I was doing this project and I put regular tap water in all the tubes and I put vinegar in one. They were all acidic because our water was acidic enough to the phenylalanine to convert. So your normal home water is probably going to be a little on the acidic side, possibly a little bit on the basic side. I don't know. I've never seen basic water, but I'm sure it's out there. But for the most part, deionized water should be a pH of 7.0. Normal physiologic pH, so in the body, our normal pH, remember we talked yesterday, that tiny little area, 7.35 to 7.45, narrow range. This super narrow range is what we have to keep in to keep our body functioning well. You can go into acidosis or alkalosis if you do not keep it within that tight little range. You'll learn a lot about that when you get to chemistry. Normal urine pH runs about 6.0, a little on the acidic side. So what does that tell you about urine compared to blood with respect to hydrogen ions? More hydrogen ions in the urine compared to the blood, correct. So pH stands for potential of hydrogen, indicates the degree of acidity or alkalinity of a substance. Okay, here's a normal pH. Very acid, very alkaline. Very acidic, battery acid. Very, very acidic, 0.3. Super, super acidic. Bleach, 13. Very, very alkaline. Either end of those are toxic to people, right? We know that we can't like bathe in bleach. We know that's not good for us. We know that we don't want to be messed with battery acid. We know that's not good for us. So some other things just kind of interesting. Stomach contents, 2. Orange juice, 4.2. Skin, 6. Skin is a little acidic. Baking soda, 8.4. Ammonia is 11. As the hydrogen ions increase, the pH decreases. As hydrogen ions decrease, the pH increases. One thing, I'm going to step on my little soapbox. Alkaline water. You're drinking alkaline water and it's going into a pH of 2 stomach. Is it really going to make much difference? People say, oh, but my skin looks so much better. Well, it looks better because you're drinking water, right? My opinion on the matter, you know, I always think it's funny, you know, oh, eat an alkaline diet, eat an acidic, you know, whatever. It's like, you know what, when you're dealing with a pH of 2 for your stomach contents, yeah, if you're only vegan, it's going to be a little bit different. If you're, you know, major meat, it's going to be a little different. But for the most part, not much is going to change. So, regulation of the body pH, that's 735, 745. You're going to hear this over and over and over and over and again. There's a reason, right? You're probably going to see this on a quiz coming up. There's only, when you have only slight variations around that, you can cause death. Like our body cannot handle much outside of either of those ranges. 2 organs that are primarily responsible for blood pH. One is the lungs. I'm not going to teach you about the lungs. You'll get that in chemistry. The other is the kidney. That's my area. Bow will cover kidneys again when you get to chemistry in a little bit different of an area. But the lungs and the kidneys are what really maintains that pH to be very, very narrow. If that pH is not maintained, if it drops too low, your body goes into acidosis, or if it goes too high, it goes into alkalosis. They can occur from either metabolic or respiratory situations that can cause either one of those. So when we're dealing with kidney physiology, so you know, we're urinalysis, we're going to talk kidneys. What we're looking at is both secretion of hydrogen and ammonia removing excess hydrogen ions from the blood in that distal convoluted tubule. Remember I told you last time, proximal and the distal tubule. With the distal tubule, the one thing I want you to always keep in mind is the hydrogen ion balance. That's, other things happen in that tubule, but that is the prime function when we are talking about things happening in the kidney. The distal convoluted tubule is where the hydrogen ion balance is going to occur. So the body will actually secrete, or the body will secrete it into that distal convoluted tubule, or the body will reabsorb it. Like if the pH starts getting a little too basic, it'll be reabsorbing some of those hydrogen ions. Excess acid gets excreted into the urine and stored in the bladder. That's why our first morning specimens tend to be a little more acidic, because overnight our body's just kind of excreting those extra hydrogen ions that we're not utilizing. So a random urine, 4.5 to 8. Huge range. Why do we care? Because it'll tell us maybe what crystals we're looking at. If you're always low or always high, that gives us clues too. First morning, always a little acidic. After meals, it's going to be greater than 7. This is so cool, okay? After a meal, it becomes basic, because you think about it. Eat food. What does your stomach need to digest all that food? Acid. All these hydrogen ions are going to be going to the stomach to help you digest, so there's not as many for the body to excrete. So there's not as many being secreted into the urine because the stomach is using them all. So that's called the alkaline tide. Is you get this alkaline tide after meals because your stomach needs the acid. It needs those hydrogen ions for breakdown. I think that's really a cool way of like thinking through what's going on with the hydrogen ions in the body. So what causes abnormal urine pH? Improper storage of the urine. First and foremost, if we see a pH of 8 or greater, chances are really good that urine got collected, put down, and forgotten somewhere. Okay? pH goes up as the urine stands because the hydrogen ions are going to combine with the bicarb, carbonic acid, and et cetera, et cetera. It's going to make the pH go up as the urine stands. Certain bacteria can convert the urea to ammonia also, which is going to increase the pH of the urine. If we get a pH of 8 or greater in the lab, most of the time, the first thing we're going to do is call for a recollect. Because if it's greater than 8, chances are it was sitting for a while. Now, why does it sit? Let's think about it for a minute. You're a nurse on a floor. You collect a urine. You set it on the patient's, counter or whatever, and then there's a code suddenly next door. Or there's somebody in the hall that's having a problem, or there's something going on someplace else. By the time they get back to it, they're like, oh yeah, that urine. So they're going to label it, time it and date it for that time that they're labeling it, and send it down to the lab, okay? We don't know what's going on the floor. We don't know what caused that urine to sit. It could have just been forgotten about. That happens too sometimes. But always remember when you're looking at different things, you got to remember that you don't know what's happening on the floor, so do not get nasty about it. Don't get rude. You're not on that side of the bed, okay? You'll hear me talking about this multiple times. Like sometimes we'll make fun of like the nurse's lab, but that's not really good for us in the lab world because we all need to work together and we need to respect each other and respect each other's specialty areas. So that's what sometimes happens with these things. We don't know what's going on the floor. Other reasons, diets. Like I said, vegetables and citrus fruits are more alkaline. When you eat a high protein diet, your urine's gonna become more acidic. Certain drugs cause different issues. Alkalizers, decrease formation of kidney stones. If you're somebody that develops kidney stones, you may take medicine to like keep your urine less acidic. Acid drug therapy, certain drug therapy inhibit the growth of urea splitting bacteria. So there's certain meds you can take that will affect the urine. There's certain meds you take that will affect the urine as a byproduct, not intentionally. Sometimes it's intentional, sometimes it's just a side effect. Respiratory alkalosis, respiratory acidosis, different ways your lungs work. Again, you're going to focus on that more in chemistry. I'm not going to get into that more, but they will affect urine pH. Metabolic reasons, metabolic alkalosis, vomiting. If you're vomiting, you're removing a lot of those hydrogen ions, and because of that, your stomach doesn't have as many. Your stomach doesn't have as many. The body's going to reabsorb more, and then your urine is going to be more alkaline. Metabolic acidosis, starvation, diabetes, malnutrition, diarrhea, etc. All of these are going to increase hydrogen in the urine. Renal tubular acidosis. It's a kidney defect where the tubules, we talked about the tubules, right? And the nephron, proximal, distal, and the loop. It's where the distal convoluted tubule is not able to secrete the appropriate amounts of hydrogen ions. So the tubule itself is not working well. And so because of that, we're going to end up having a more acidic urine. I'm sorry, more alkaline urine. More acidic in the bloodstream, more alkaline urine. So again, lots of things we can tell for other reasons, but the importance when you're actually doing a urinalysis is certain pHs are going to affect your cellular elements. Certain things, if we allow an alkaline pH, if we have a urine that's highly alkaline, there's a really good chance it's going to break down our red cells, our white cells, our casts, our crystals. So we may miss things that are there because of the highly alkaline urine. Consistently alkaline pH on freshly voided urine oftentimes means we have a urinary tract infection going on. So if it's consistently high, first thing we do is ask for a recollect. If we get the recollect and we know it's fresh and it's high again, now we know that it's probably a real versus bacteria that's been just allowed to grow in that yummy urine broth that it loves so much. Crystal identification. When we're looking at crystals, some crystals happen in acidic urine, some crystals happen in basic urine. So when you're looking, it helps determine and break down because some crystals look very similar. And so it helps us guide us to which direction we're going to be looking. When we get to that part of our class, you have these really nice pieces of they've got different pictures on them. It's a urine atlas, we call it, but it's different sheets. One is acidic crystals, one is basic crystals, one is neutral crystals, and we have red cells and we have white cells. So you have all these sheets to look at to help you identify what you're looking at. But the first thing you're going to do is look at what the pH of the urine is to guide you down the path that you need to find. So the principles of the urine dipstick, it's a double pH indicator, okay? And what that means is there's two indicators. We've got a methyl red and a bromthiamyl blue. And the two together, depending on what the pH does, creates a color change. So, for example, pH of 5, the methyl red is an orange color and the bromthiamyl blue is a yellow color. That's going to lead us to an orange final. The yellow and the orange is an orange color. pH of, I'm just going to drop, I'm not going to read them all, you can read through them. pH of 9, the methyl red becomes yellow, the bromthiamyl blue becomes a dark blue, and so you end up having this like dark blue green out of a 9. So it's these two indicators that both change color depending on the pH, and therefore we get this nice range all the way from orange to yellow to green to blue, depending on what we're looking at. So it's a double pH indicator is our methodology. So you'll see that written out places, you'll have to write that out places. It's a double pH indicator. So interferences for measuring the pH, none that we're aware of. We don't know of any interferences that are going to cause any problems. However, we can have falsely elevated pHs, things like improperly stored room temperature urine. The bacteria is going to grow, you're going to get an increased pH. A lot of times, remember, the older urines also become brown, and that's going to be, so you have a high pH and kind of a brown color, it leads you to believe that it's probably going to be an alkaline pH. Couple precautions. You want to make sure if the strip is wetted excessively. We don't want to, like, you know, hold it in the urine or have those big bubbles on the top of it because the protein has a pH buffer. And what happens if it sits too much, it'll actually contaminate it and go over. If we hold it upright too much and don't put it down horizontal, it'll actually have override from the protein buffer. Confirmatory test, if needed, we can use a pH meter. For the most part, the strip gives us a clue because remember, it's only telling us what to look for mostly for crystals, what's kind of going on. It's an overview. It's a very basic general screen. Here's the objectives for the urinary pH. Again, they're on the other form. Here's some of your key terms. We're going to jump into protein. So proteinuria. We need to be able to recognize normal and abnormal protein levels when we're doing these analysis. So amounts of protein in the urine. Proteinuria is any sort of abnormally high levels of protein in the urine. We shouldn't see any. On our regular routine dipstick, there should be 0. We shouldn't see it because the amounts going through are so minute, we're only going to see them in once they hit larger numbers. What urinary physical property indicates the patient is suffering from moderate or large proteinuria? Let's go back to physical properties. What's it going to be? The last lecture we talked about physical properties of urine. High protein, what are we going to see?
Foamy.
Foamy, white foam. When you do that swirl and the vigorous shaking, you're gonna get white foam. That's a real key that we're likely to see high protein in that urine. When we actually are worried, once we have anybody with slight amounts of protein, most of the time we're gonna run a 24-hour urine to determine how much protein is actually going on in that urine or how much we're losing. Diabetic patients, we do this routinely because the diabetes ends up affecting the kidneys long term and you end up with proteinuria and kidney disease. So normal range, less than 150 milligrams total in 24 hours. So that's not a lot in a 24-hour period. Mild, less than 1 gram in 24. Moderate, 1 to 3 or 4 grams in 24. And then large proteinuria, greater than 3 to 4 grams in 24 hours. When you get to this point, you got some major kidney damage, right? Because that sieve that we have, that glomerulus, we've got so many holes. It's that 20-year-old colander that your mama and dad have up in the cabinet that all the spaghetti noodles fly through. That's what we're looking at when we're looking at high proteinuria. So the kidney, molecules between 50,000 and 60,000 molecular weight or less are going to pass through the glomerulus easily, right? We've talked about that. It's small. They're going to flow right through the sieve. Albumin, we're looking at about 67,000. Occasionally it's going to kind of sneak through, but for the most part, it should be big enough not to go through. Anything that does go through, usually the body's going to say, excuse me, you need that back, and it's going to reabsorb it as it's going through that proximal convoluted tubule. So most of the time, a little bit that does sneak through, the body's going to reabsorb, so we're never going to see it. We're not going to see it on a urine dipstick. Usually it's too big to pass through, not going to be an issue. So sources of protein in the urine. When we start seeing protein, what's going on? Bloodstream proteins, albumin. Like I said, it's the major serum protein that we find in urine because it's one of the smaller serum proteins, and it's going to be the first one to start sneaking through. It's going to be the first sign that we have this glomerular damage, so we're likely to see more and more of it because it's going to be small enough. When you start getting that damage, more and more is going to come through. Globulins, sometimes we'll see other globulins in the urine. Now, there are kidney and urinary tract proteins that actually are produced in the kidneys and in the urinary tract. Our dipstick method, we specifically look for albumin. However, uromodulin used to be called Tam Horsfall protein. Every once in a while, you'll still see it referred to as Tam Horsfall. If you have to look it up, it'll come up as uromodulin. It's produced by the kidney. It's a protein that's just produced by the kidney. It's easily excreted. We don't care about it. We know it's going to be there, so we're not going to test for it. I shouldn't say we don't care about it. When we get to CAST, we'll talk about why we care about it a little bit more. But for the most part, it's normal. We see it. Urokinase is a fibrinolytic enzyme that's produced in the kidney. IgA, it's a secretory immunoglobulin. You guys learned about that in BIC. It's produced in the kidney. We do not care about testing for those most of the time unless we're specifically looking for a problem. The dipstick looks for albumin. Another source, vaginal contamination. Vaginal contamination often also is a cause of higher protein in the urine. Most of the time, we're not going to see it though because it's not albumin. The strips are specific for albumin. So, types of proteinuria. Multiple times during this class, we're going to talk about pre-renal, renal, and post-renal. So, pre, before the kidney, renal, in the kidney, post-renal, after the kidney, right? Pretty basic, but I want to talk about it now because we'll keep talking about things like this. So we see pre-renal, sometimes with glomerular and tubular, which is part of the renal, and then the lower urinary tract, which is post-renal. Clinical symptoms of protein disease, we can have acute, chronic, or asymptomatic. So we can see multiple different types of proteinuria. Prerenal disorders. Different things we'll see before the kidney. Overflow proteinuria, increased concentration of those low molecular proteins that are going to pass through the glomerulus. Sometimes we'll see these Benz-Jones and multiple myeloma. You guys learned about multiple myeloma and basic immune concepts, right? So sometimes these Benz-Jones proteins, they're really, really small. They're going to go through. Our sticks won't determine them. We have to do a specialized urine test specifically looking for them. Hemoglobin and myoglobin can sneak through the glomerulus. Those will be picked up on the blood pad of the dipstick. Again, the protein pad will not pick those two up, but we will see those. Those are things that happen before the kidney that can cause proteins in the urine. Changes in hydrostatic pressure, hypertension can cause, remember that the glomerulus is already under high pressure. Hypertension is going to cause it to be even more. It's going to push some things through. So sometimes you'll see extra prerenal disorders such as hypertension, congestive heart failure, and dehydration that can also cause increased proteins in the urine. Glomerular proteinuria, toxins, infections, vascular disorder, immunological disorder, all of these things are going to cause glomerular changes. And when we start seeing glomerulonephritis, which affects the glomerulus, we start seeing more protein. Post-streptococcal acute glomerulonephritis. You guys talked about that in BIC also, right? You get the strep throat, and then those antigen-antibody complexes land on the glomerulus and start causing damage. And because of that, then we start getting holes in our glomerulus. The colander holes get bigger, the spaghetti seeps through, our albumin is going to seep through. Other things you're going to see with this, you're going to see a positive protein on the pad, but you're also likely to see positive blood. And your urine sediment, you're likely to see red cells and red cell casts. We'll talk more about casts later. Tubular proteinuria is when you have tubular disease. There's tubular damage, things happening there. Acute pyelonephritis, which is a kidney infection, we're going to see moderate proteinuria on the strip. We're going to see the albumin, positive nitrites, positive leukocyte esterase, and in the sediment, white cells, bacteria, and casts. Acute renal failure or acute tubular necrosis, dying of the tubules, we're likely to see mild proteinuria, and urinary sediment is going to have granular and waxy casts. Drug-induced acute interstitial disease, allergic reactions. Urine sediment is likely to have eosinophils in addition to red cells and white cells. Lower urinary tract diseases and disorders, cystitis, bladder infection. That's going to be one of the most common ones we see. You're going to see mild proteinuria with that one. Nitrites, leukocyte esterases. And when you're looking at a white cell or a urinary sediment, all these little spots, those are white cells. This is a big squamous epi. We'll have a couple lectures on what we're looking at here. But just so you know, that's kind of what we see, all these white cells. Your urine shouldn't have anything in it. A good healthy urine, you look under the microscope and you can't even see it, right? You have to find like 1 or 2 cells somewhere to focus on because nothing's there. When you see something like this, like, whoa, that's an infection, major infection happening. And actually this one, you can even see some bacteria here. This is bacteria, that's bacteria. Some of these little spots are bacteria.
Some mucus too. Some mucus too.
Yep, there's some mucus in there too.
Is that a trichomonas?
No.
Oh. No, they look like little mice. Do they?
Yeah.
Kind of fun. Like,
they are kind of fun. I used to be able to get trichomonas from UW Hospital and bring it in and spike some urines, and they don't have live trichomonas anymore, so I can't do it. And it's really expensive to buy for one lab because I looked into it. I'm like, oh, I can't do that anymore. Wow. We'll show some videos with it. We'll have some videos. Asymptomatic proteinuria, stress due to excessive exercise, exposure to cold, things like that can happen. Pregnancy due to toxemia, postural or orthostatic proteinuria. What that is first morning specimen. You have protein, you don't have protein in your urine, but as you stand all day, there's pressure on one of your renal vessels that causes protein. That's one of your study guide questions. One of your homework questions talks about orthostatic proteinuria. Orthostatic proteinuria. Words are hard sometimes. Normal individuals have a little transient proteinuria sometimes. You know, you just don't feel well, something's going on, it comes, it goes, it's not going to be a big deal. It happens, sometimes you have it. It's the consistent that becomes problematic. Renal disease patients have consistent proteinuria. You start getting renal failure, renal diseases, we start seeing more and more of it. Asymptomatic proteinuria, stress-induced uromodulin. And when we see that, this uromodulin, we'll talk more when we talk about the cast, but it actually makes this cast formation. So these casts are made of uromodulin, which is a protein. Think of it like Jell-O, right? Clear gelatin, not like the red Jell-O, but like clear gelatin that you can get. When it solidifies, that's kind of what we're dealing with here. It's the protein uromodulin that makes these casts. Screening versus confirmatory tests. For example, a dipstick versus a 24-hour protein. Dipstick is a screen. It's a point of time, right? It's one urine, one time. We want to know how much protein is actually there. We do a full 24-hour urine to see what's going on. Qualitative versus semi-quantitative. Qualitative is a number. It's a value. Backwards. Qualitative is yes or no. It's there, it's not there. Semi-quantitative gives you a number. 30 milligrams per deciliter, for example. Qualitative, the 1 plus 2 plus is just like, yes, it's there in kind of a random amount, but the 30 milligrams we look at as semi-quantitative. Sensitivity versus specificity. Sensitivity, amount being detected, how little is detected. Specificity, reaction only with the compound being tested. So sensitivity, a test that is very sensitive will have very few false negative results. It's very sensitive. It'll pick it up if it's there. Specificity, it's going to be very few false positives. When it's positive, it's there. There's not other things that are going to make it turn positive. So the urine protein test, the methodology is the protein error of indicators. And then there's also a precipitation test that we'll talk about called sulfosalicylic acid. We actually do this one in the lab. We'll talk more about those a little bit farther down. We'll get into it. So within the lab, you can test all urines for both, or a lot of places confirm only the positive strips with the sulfosalicylic acid test. That's how we do it. We only confirm them. If the only time we ever do this is if the pH is 8 or greater, so strongly alkaline, and the sticks show greater than or equal to 2+. The reason we do that is because of the overflow of the buffer. If it's a highly acidic urine, it'll actually mess with the buffer on the pad. So the principle of this protein error of indicators, certain pH indicators show a change. It's tetrabromophenol blue indicator, and then this other. Yeah, I'm not making you learn that, okay? This is why we call it the protein error of indicators, because I don't know how to say that. I'm not going to try. Now, the big thing is there are buffers on the pad to maintain that pH. And the buffer maintains the pH of about 3. So pretty acidic. It maintains that pH. Therefore, any color changes, the urine protein is indicated. It's especially sensitive to albumin. Primarily, most of these streps are sensitive to albumin only. Sometimes the globulins might make a little bit of a factor, but for the most part, it's only going to be looking for albumin. You will see that one again. So here's a kind of a diagram of what's going on. Whoops. Normal urine, no protein. The protein pad of 3 is maintained by the buffer, no issues. Urine with 2,000 milligrams of protein, the protein pad stays a pH of 3, maintained by the buffer, and it kind of turns to this blue color. Now, one of the problems we have is if we have a highly alkaline pH, it's going to override the buffer. So remember in chemistry, you did these tests where you did drip, 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 drip to see how much it took to override the pH to a certain point. You had to add a whole lot of base to turn the acid pH to change the number. That's kind of what this is. It's good to a certain point, but once it hits a certain point, it's gone. So what we have when we have a highly alkaline urine, we need to know, is it the alkaline urine that affected the pH, or is it the protein that affected the pH? That is when we do the confirmatory test of the sulfosalicylic acid, if we have a positive test and a high pH. Okay? So, what else causes false positives? Strongly pigmented urine. That pyridine is going to affect all the colors, right? It's going to stain everything. Other pigments, if it's a really bloody urine, the pigment of the blood is going to affect the color pad, things like that. Highly buffered alkaline urine overpowers the acid buffer on the reagent pad. That's what I was just talking about. Highly alkaline urines make that buffer go away, and you get this false positive. And then we do the confirmatory that we'll talk about. Contamination from a quaternary ammonia cleaning, disinfectant residue. This is really important that we clean our areas and let them dry completely. And we're going to put a pad down on the table and do our work on a pad so we aren't having those contaminations of our cleaning agents. Loss of a buffer due to repeated dipping. You put it in, you hold it in, it's going to lose the buffer. You swirl it, swirl it, swirl it, swirl it, and kind of mix it and hold it in for too long. Repeating dipping up and down, any of that, you're going to lose the buffer on the pad, and you're going to have a false positive result. That's why we dip it, one little swirl, pull it out. So if we have a positive and the pH is really high, that's when we're going to do the sulfosalicylic acid precipitation test. It's a precipitation test, and I'll get into that in a couple slides. False negatives for urinary albumin. Proteins other than albumin could be present. So we're going to say no protein, but it's just that it's no albumin. The other proteins could be there, we just don't test for them. Reagent strips are unaffected by turbidity, radiographic dye, most drugs, metabolites, and urine preservatives. So thankfully, there aren't a lot of things that are going to get in the way of these tests. So the sulfosalicylic acid test, the SSA, you only have to call it the SSA. I'm not going to make anybody spell the sulfosalicylic. I just think it's fun to say. You know, some things I stumble over, I just love that word. I don't know. So it's a protein precipitates in the presence of sulfosalicylic acid. So what we do, it's in your lab manual. Again, do not memorize the procedures. Never memorize, I mean, you can memorize how to dip, you know, because you're going to be doing millions of those. But for the most part, when you have these other procedures, your instructions are always going to be with you. So you mix equal amounts of centrifuged urine and SSA. We have to centrifuge it if it starts cloudy. If it's a clear urine to start, you don't have to worry about it. But if it starts cloudy, we're going to be looking for precipitant. And so if it starts cloudy, is that our base or is it precipitated out? So we want supernatant if it is a cloudy urine. And we're going to read the degree of turbidity against a lined printed background, and then we're going to report these out this way. So you can see here, this one's very turbid. You can't even see the lines behind it. And there's actually a picture in your lab manual about what a 1 plus 2 plus 3 plus 4 plus or a negative is. So interferences, false positives. If it's turbid by any other means, you need to centrifuge it first. You want to check the patient's chart for X-ray dyes. X-ray dyes will create false positives of the SSA. It's not going to affect the protein pad on the dipstick, but it will cause a false positive on an SSA. However, if you have a negative on a dipstick, you're not going to be doing the SSA. So you shouldn't, I mean, it shouldn't trigger, shouldn't be a problem. False negatives, highly buffered alkaline urine is going to neutralize the acid. Wait a minute. A highly buffered urine is going to cause a false positive dipstick protein. And now it's going to cause a false negative SSA. So you just have to keep that in mind when you're doing it. Like, oh, wait, what's going on here? The other false negative is the urine is super dilute. There may not be enough to actually catch, because you know you need a decent amount to actually see it when you're looking at the precipitant. So sequence for chemistry workup for proteinuria. Random urine reagent strip is positive. Okay, it's positive. A lot of times it'll be like, yeah, one positive, not a big deal. But now you get another one's positive. It's like, okay, patient's had a couple positives. What's going to happen? We're going to look at the pH. If pH is super alkaline, we're going to run the SSA. If it proves to actually be there, now we've proven it's there. So the physician then is going to want to collect a first morning specimen, which could be the most concentrated to check for proteinuria. They're going to retest to make sure it's just not a transient. Like I said, some people just once in a while have protein in the urine and it goes away. If it's positive, then we're going to do a 24-hour specimen to see what's really going on and how much over 24 hours is going. If it's positive, we're going to do a protein electrophoresis, maybe in order to determine the type of protein present. Now, a dipstick is going to be specific for albumin, but what if there's other things present too? It may trigger that other things might be there. So we're going to collect, measure, and calculate a 24-hour protein concentration. Patients with a negative, they're negative on dipstick or SSA, yet maybe positive for microalbumins. So when do we do this? A lot of diabetic patients are going to get microalbumin tests to see, because it's an early indicator of kidney disease. Methods, nephelometry, radioimmunodiffusion, special strips. The lowest amount on a regular dipstick we're going to see is 30 milligrams per deciliter. So if it's less than that, a regular dipstick may not pick it up, and that's called a microalbumin test. Sometimes we're going to do protein electrophoresis. So what that is, phoresis means separation, electric current. You guys talked about this during basic immune concepts, right? You guys saw the graphs, how that all works. And then there's various proteins in the proteinuria that are going to be significant for different diseases. You guys talked about this in basic immune concepts, so I'm not going to spend a lot of time getting into it, because for our purposes, I'm not going to be quizzing you on this stuff. This is just stuff to kind of like bring that back to remind you that, oh yeah, we did that. This is now how we get to that point. So here's one of those gels. You got your graph there. As I said, I'm not going to spend much time on that because we've spent a lot of time before. So we got a couple examples here. Reagent strip and SSA results. What does it mean and what should we do? So patient 1, reagent strip is negative. The SSA is negative. What's our interpretation? Patient's negative, right? Move along. Example 2, reagent strip is positive. The SSA is positive.
Report positive.
Yep. And now this patient's positive. Now the doctor has to figure out what their next steps are. We can't go ahead and order the next steps, right? Be nice if we could. That's what the DCLS is good for. If you had our DCLS people that are actually starting to work in labs are ones to like make sure to trigger the doctor to order the next steps and follow up on patients. Example 3, my reagent strip is positive. My SSA is negative.
Could be false positive.
Could be a false positive due to
A basic pH.
a high basic pH. Good, yes. Super high basic pH. Now you're gonna notice example 4 is the exact same way, right? So that's one possibility. What's another possibility with this type of situation?
Too much dipping?
Could be too much dipping. That's a good one. Yep. Problems with how you do the procedure. We haven't gone over it, but what are our limitations? Our strip picks up at 30. What does the SSA pick up at? Does this one cover that? It doesn't. Oh, this one's not covering it. The SSA sensitivity, though, is a little bit higher. So you could potentially have a false SSA due to that. In this situation, it was false positive due to the alkaline pH. Check pH. You can actually adjust it. The other option is possibly due to drugs or x-ray dyes. Remember the SSA, false positive due to some of those drugs. So in a real world, if the strip is negative, we're not going to be doing the SSA, so it's not going to happen. But if you did for whatever reason, that could be part of the reason what happened. Certain drugs and x-rays. Good. Key terms. Lots of key terms here. Make sure you're going through them all. Objectives. More objectives. Lots of objectives. We're starting to hit some of the deeper lectures.